In the fall of 2017, neurologist Dr. Randall from NorthShore University Health System spoke to a group of Myasthenia Gravis patients. He addressed men's and women's MG issues. Here's his presentation.
So women are overrepresented in myasthenia. You'll see it in most support groups. Apparently you'll hear more in how they talk in the support groups from what we just heard. And depending on which numbers you believe, 60% or more of affected people are women. And women tend to be affected at a younger age. The highest incidence for women traditionally has been in the 20s and 30s. However, if you look at the group of people that are here, you'll find that actually at older age is being diagnosed more frequently, and there's more people being affected. That's a trend that will continue as the population ages. There is some genetic correlation with an HLA antigen that increases your susceptibility to having it, so there is some genetic basis for it, but it's a very complicated genetics. And there's other genes, particularly in women, that make you more susceptible for autoimmune diseases, putting sort of these younger age women at higher risk. Men are also affected in great numbers, but over 50 years old is more common than the younger age group, and even 70s and 80s. So certainly a problem for both sexes. When we talk about exacerbations, talking about people with myasthenia who are worse for some reason, beyond the every day-to-day fluctuations. Nobody with myasthenia stays exactly the same all day long, but exacerbations when the symptoms are much worse beyond the typical baseline. And so a lot of things that you should remember that can cause that so you can address those problems. First is infections. Most people who have myasthenia realize that in the winter, when infections like my cold here is more likely to happen, myasthenia can get much worse. So it happens equally in men and women. Anesthesia for any procedures can be worse, particularly general anesthesia, and particularly if they use a neuromuscular blocker. So something that affects the muscle can make myasthenia much worse. Thyroid changes, either high thyroid or low thyroid, also make the symptoms of myasthenia much worse. And medications. There was probably on the table, although I don't recall seeing it, there's a whole list of medications that you should all have with you somewhere that you take with you so that you know what medicines you shouldn't take or should be cautious of with myasthenia. Because medicines can certainly make it worse, particularly some of the antibiotics, calcium channel blockers for some people. And then there's some medicines that you should never take, one of which is penicillamine, but I don't think anybody takes penicillamine anymore, so it's sort of a moot point. So emotional stress can cause worsening, and I never knew how much emotional stress could cause worsening, but I've had several patients that have been diagnosed and become critically ill. One woman I saw a number of years ago, her 97-year-old mother passed away, and she ended up in the intensive care unit. So it's definitely a major factor in exacerbations. Physical stresses of illness, trauma, surgery, both affect both sexes equally. Now, where women have the opportunity to have more episodes of worsening are things related to the period, menses, pregnancy, and the postpartum, where after you have a baby times. And we'll talk about those times as well. They can cause significant and almost expected weakness at some of those times. So women affected more and affected younger during childbearing age. So a case I do want to mention is I had a 14-year-old girl who was referred by her obstetrician gynecologist, and she was experiencing menses-related fatigue and droopy eyes as well as double vision that tended to start 2 or 3 days prior to her menses and lasted for 0 to 5 days after her menses started. Her pediatrician sent her to a social worker to treat her for depression because of the complaints of weakness that she had. Vague weakness, didn't understand it. She was finally sent to an obstetric gynecologist who said, no, this is not related to that, and I saw her and she clearly had myasthenia gravis that was just getting worse during the menstrual cycle. So there are a group of small studies and case reports demonstrated frequent exacerbation of myasthenia during the menstrual period. And the biggest study I could find is a 42-person study where they looked at premenopausal women. And the general disease, they found 2/3 of them had exacerbation of their myasthenic syndromes 2 to 3 days prior to the menstrual period. And that worsening could last as long as 3 to 5 days after the period started. And many of them, I think 9, had to actually have changes in their medicine related to the menstrual period. And the exacerbations occur both in seropositive, which means that you have the acetylcholine receptors antibodies, as well as seronegative myasthenia patients. And often you do have to change the medicine regimen because of that. So I have tried, and others have tried, and nobody has yet been able to prove beyond sort of a confident interval that the benefits of long-acting birth control pills will limit these exacerbations. Thought was, and I thought it was a good thought, that if we prevented having the cycle as often, it would allow the weakness to be less often. So these seasonal things last 3 months. But the truth is that there must be some variation within them that has not made it as effective as I would have hoped it would have been. Some people do it and still have benefit. There certainly are reports of it's helping, but not more globally proven. The good news, menopause tends to improve some of these hormonal fluctuations that cause some worsening. So there are people who had both natural menopause and even surgical menopause that they've had for a different reason and get better with exacerbation. So it's always good to have some good news on menopause. So I had a 32-year-old woman who had 15 years of myasthenia gravis. She had a thymectomy 13 years before. She'd never needed to be hospitalized or intubated because of myasthenia, although she'd been to the emergency room on a couple occasions. She had frequent exacerbations. She was on moderately high prednisone, 25 milligrams a day, and azathioprine, 200 milligrams a day. And she took methadone. She took 80 milligrams a day, so a lot of tablets of methadone. And she was considering pregnancy, and the question was, can she get pregnant or not? What are the risks? And what I tell everybody is that they need a plan. If you want to get pregnant, you need a plan, preferably before you get pregnant. Because if you get pregnant and you're on a variety of medicines before you're pregnant, the first 12 weeks are extremely important in pregnancy. And you may not know for 4 or 6 weeks being pregnant. So you want to plan before. So the neurologist should be the first to know that you're thinking about conception, obviously. Is pregnancy an option? Can medicines be eliminated? Because often we can adjust medicines. Can an exacerbation be avoided? And what are the plans if there is an exacerbation? So you have to know that things could get worse. And if medications are needed, what's the risks, both the fetus and the newborn? And what are the necessary changes in the medications? And then the second thing is the effects of pregnancy on myasthenia gravis. Because myasthenia gravis will not stay the same during a pregnancy. Let's talk about a few. So, if you're planning pregnancy, you need a team. You need a neurologist who does neuromuscular disease, and you'll need close monitoring. You'll need high-risk OB. Nobody with myasthenia should go through pregnancy without high-risk OB. And then after birth, you need a neonatal pediatrics, which will require planning to have neonatal pediatrics around. What do you need to consider? Well, you need to see how stable the disease has been and the severity of the disease. Have there been crises? Have there been exacerbations? How long has the patient had myasthenia gravis? So, how many people have had their myasthenia for more than 2 years? More than 2 years? How about more than 7 years? 7 years? So, the advantage of having it more than 2 to 3 years is that you get some idea of how bad the myasthenia will get. 2 to 3 years, most people have declared if they're going to need hospitalizations. Most people have declared if they'll need to be intubated. If you get through the first couple of years without that, the odds are much better going forward. If you get to 7 years, most people's disease, most people will actually have some improvement in their myasthenia if you get out to 7 years with myasthenia. So optimally, you'd say, well, if that's true, wouldn't it be good to wait 7 years before somebody got pregnant rather than 2 or 3? Most people don't plan pregnancies almost a decade in advance. So you know, in high school, you try to just prevent pregnancies, but if you can wait 2 years to kind of see where it will be, you're in better shape than if you don't. So, poorly controlled disease is a relative contraindication to pregnancy. A relative contraindication to pregnancy. That doesn't mean you should get pregnant. It means that you should get better control before you get pregnant. It's a matter of getting things treated to a place that is safe to get through the pregnancy on medicines that are safe to get through pregnancy. So, part of the team. So, consideration. So, like we'll talk about the effects of myasthenia on pregnancy, and the effects of pregnancy on myasthenia, and how you need to adjust the therapy. There's a risk because the antibodies do pass through the placenta that the fetus won't move enough, and it can cause these joint contractures. There's also a slight increased risk of fetal loss, things that people should be aware of for pregnancy. But you should also be aware that successful pregnancies in healthy babies are the most common outcome. So there are risks. The risks are greater, but there's still a way to get through with healthy babies. Most common outcome. So my patient stopped her azathioprine. She didn't change the acetylcholinesterase, the methadone, or the prednisone. She stopped birth control 8 weeks after she stopped azathioprine. And then she failed to report some increased symptoms of persistent ptosis, mild neck weakness. Missed a 12-week follow-up, where I would be able to see that. And then mazel tov, 4 months later after stopping it, she was pregnant after stopping the azathioprine 4 months later. So, pregnant, not in the optimal situation, but pregnant. So, what happens with pregnancy? Well, you can develop an exacerbation about a third of the time if you have myasthenia, but that means almost 2/3 of the people won't have an exacerbation during pregnancy. There's also the initial diagnosis that can occur during pregnancy as well. Unfortunately, the severity of symptoms before pregnancy doesn't reliably predict the course of your pregnancy. So you can be doing well before pregnancy and do poorly during part of pregnancy, but most people get through, and you can be doing poorly before pregnancy and still be able to get through. So you just have to be able to work with your doctors. So exacerbation, crisis, and remission, so people can get worse, can be in intensive care unit, and even can get better, all within the same pregnancy. We'll talk about why that happens. So, as I said, 68% unchanged, 20 to 40% will worsen, and I plan for everybody to get worse. Not because I'm a pessimist, but because good planning makes it much simpler when you get the call that things have gotten worse. And if you know things may get worse, you're more prepared to deal with it. So the highest risk is in the first trimester, in the final few weeks of pregnancy. And we think in the first trimester there's a lot of hormone changes, and it seems like it boosts antibodies in that first trimester. So the first trimester tends to be the rough time. The second trimester tends to be pretty well controlled, as is most of the third trimester. So if you can get somebody through their first trimester, they usually will have a fairly uneventful pregnancy. And we believe that's because of alpha-fetoprotein. And alpha-fetoprotein, if you've had, anybody's had amniocentesis and things, they look at AFP levels, and this protein is related to pregnancy. But what it does, which is wonderful, is it inhibits the bonding of acetylcholine receptors on the antibody. So if you remember from the first graph, one of the problems was you couldn't get to the receptor sites. With alpha-fetoprotein stopping the antibodies, it relatively treats myasthenia, and so they actually do better as long as you have the alpha-fetoprotein. In the third trimester, you can imagine that as Jackie's not, so if you get larger and larger in your pregnancy, if you get larger and larger, you're going to squeeze the lungs and the diaphragm and make it more difficult to take deep breaths, more difficult to breathe during pregnancy. And when you get less mobile in bed, all these respiratory things can start causing some difficulties. So, end of pregnancy, difficult mostly because of sort of a true obstruction. So my patient went back to the emergency room after she reported double vision, swallowing difficulties, unable to swallow pills, and she couldn't swallow, so she requested IV pyridostigmine. Fortunately, the emergency room was cautious, and you should all be cautious, because IV pyridostigmine, unlike oral pyridostigmine, can cause contractions of smooth muscle, including the uterus. So you don't want to, particularly early in pregnancy, take IV, any of the IV acetylcholinesterase inhibitors. So high-risk OB got involved. We treated with a small dose IVIG, steroids, and she responded quickly. We did increase her risk by doing that, but we needed to get her through. And this was just to remind you about the lungs. And if you imagine having a baby sitting below, pushing up on the lung fields, imagine that there's not much air you can move, so the diaphragm becomes less and less effective. And they say up to 1 in 5 may require mechanical ventilation. I think the notes are I think the true number is much lower than that. I think that's an overrepresented number. So I don't think it's quite that scary that 1 in 5 get mechanical ventilation, but that's the number that's most widely used. And again, limited exposure. So my patient did struggle through the first trimester, wasn't able to work with severe fatigue. And as you all know, myasthenia is a fatiguing illness in lots of different ways, both physically and just energy-wise and what you can and can't do. It takes harder, more difficult to do it. So she actually had to stop work. I had to give her a note to stop working because it was more important that she was successful in pregnancy than it was that she was working at that time, so she went on disability. She actually did fairly flawless in the second and third trimesters, had an uneventful delivery. But day 1 post-delivery, she developed neck weakness, double vision, and swallowing difficulties. We had to talk about breastfeeding. Another issue with women that comes up is breastfeeding. And she chose not to breastfeed because it was clear that she was going to require immunomodulating medicine that she was uncomfortable being on and breastfeeding at the same time because there is some passage to the baby. She was treated with IVIG, we started her azathioprine, and then we started her birth control in the hospital. So you don't want to get pregnant twice too quickly with myasthenia. You want to make sure you recover. So first stage of labor, all good news. Happy little baby pushing out. It's smooth muscle contractions are not affected. The uterus is not affected, but it is a little fatiguing. By the second stage, which requires skeletal muscle contraction, it is always fatiguing. It is always fatiguing. Long term, it's frequent contractions. And it is affected by myasthenia. And at that point during the pregnancy, because they're contracting anyways, you can give oral, give IV even, cholinesterase inhibitors. In general, before delivery, we don't use them until delivery is imminent. And some people will get regional anesthesia. I would get regional anesthesia if somebody wanted me to push a baby out of my pelvis. But everybody, you can get your spinal, get your anesthesia. General anesthesia is not done as best as possible, even for cesarean sections. So use a regional anesthesia for most patients. Another complication that you have to be concerned about that doesn't happen very often is what's called preeclampsia. You get high blood pressure during the end of pregnancy, which can go to confusion, seizures, etc. It's typically treated with magnesium, but as many of you probably know, IV magnesium or even high doses of oral magnesium can make myasthenia worse. So you want to be very cautious about how much magnesium somebody gets, and if you put them on magnesium, watch for their weakness. IV magnesium definitely makes people worse. So, as for the postpartum period, so first trimester is tough, postpartum period is tough. It's often worse than 4 or 6 weeks after. There's antibodies that go away, the hormones alter the antibodies in the mother, but also the alpha-fetoprotein, which had been protective, as we said, drops off extremely rapidly. And so it is not uncommon to need treatment, IV steroids, IVIV, plasma exchange, and I think the vast majority of mothers that have had go through pregnancy have required treatment in that immediate period. As for the fetus, there's transmission of the antibodies as well, and that can lead to that decreased activity and muscle contractures. The good news, and it's always good news, right, is there's no increased risk of autoimmune myasthenia gravis newborn. So it's not that they get the myasthenia from the mother, they just get some of the antibodies from the mother. And those antibodies cause this transient weakness that you can see. Most babies get the antibodies. Most babies will get the antibodies, but only a small number, 10 to 20%, will be weak. And it can be swallowing and sucking are weak, weak cry, breathing difficulties, and it's transient. It'll resolve in a few weeks. Sometimes they'll also get acetylcholinesterase inhibitor medications to try to help them, the methadone, but most will just resolve on their own. It is more likely to happen in antibody-positive myasthenia, but has been seen in anti-MuSK as well. And if you look at every baby who's born with a myasthenia gravis mother, many of them will have the antibodies. We don't even look because treat them if they're symptomatic. So you have to be cognizant of that, and that goes away. So medicine. So one of the biggest challenges you all have, the medicines that you're being treated for, to affect your immune system. Acetylcholinesterase, including most commonly used pyridostigmine, can be used during pregnancy when as with any medicine during pregnancy, when the benefits outweigh the risk. There's limited data. Nobody's done a study on it, but it seems safe. And almost everybody goes through pregnancy with pyridostigmine unless they don't need it. As for prednisone, there's an increased incidence of cleft palate and low birth weight. The risks are small, and that tends to be the drug of choice for pregnancy to get through pregnancy. Mycophenolate. So mycophenolate, I don't know, 6-7 years ago, came out with a form you needed to fill out every time in pregnancy tests. Not everybody's fully compliant with these things, but they actually want you to have 2 forms of birth control. Because it decreases 2 things, because mycophenolate decreases how effective birth control is, and there's also substantial risks to the fetus on mycophenolate. Malformations, particularly early in pregnancy. And this is another reason why you need to plan pregnancy if you're going to get pregnant, because that's a medicine most of the time you want to avoid. Now, there's been pregnancies on all of these medicines, and it's kind of a risk-benefit sort of thing. You have to talk with your doctor and your OB-GYN and your pediatrician. But in general, mycophenolate is not used. Azathioprine also not recommended in pregnancy. Cyclosporin can be used, but there's some risks with that. Rituximab, there's some immune abnormalities you can see in the newborns. So the newborns can have immune deficiency, but otherwise not very well studied. And either plasmapheresis or IVIG, which I've used both of those during pregnancy, pretty uncertain. We do know late in the pregnancy the IVIG will cross the mom-baby barrier, but it's been reasonably safe in the right hands. And this is that form, scary form that if you're a woman of childbearing age, and even beyond that they make you do. I don't know if your doctors still make you do it if you're on the medicine, but you're supposed to every time go through this. So, as for breastfeeding, another important issue, the only couple that are considered safe, and even the American Academy of Pediatrics is pyridostigmine safe. Prednisone, there is some that crosses over but seems to be safe. All the others are either not safe or not clearly safe for a newborn with breastfeeding. And this is why some women choose not to breastfeed because of that. So women. So covering a lot of women's issues. What about men? Men don't get pregnant. They don't have menses. Right. They don't have a postpartum period. They get it at an older age instead of a younger age. There's fewer of them. Seems like better, right? So, men for myasthenia. So, there are risks to men too. While myasthenia is not a direct cause of infertility, erectile dysfunction, or loss of libido, there's more and more reports of having some relationship to low testosterone, either through the disease itself or associated with the medications for the disease. And that's a big deal for guys. because lower testosterone means loss of muscle mass and strength, changes your fat distribution, affects your bone density, hair loss, mood, fatigue, sex drive, and even sexual erectile dysfunction. So low testosterone, low T, is a big deal. And it's sort of under-evaluated in men. So what other factors myasthenia do men have? Well, it's not just related to the disease, or it's partially related to the disease, because fatigue. Fatigue contributes to that. Having a chronic illness contributes to depression. Medications can cause difficulties. And then there's a variety of associated illnesses, either other autoimmune diseases like thyroid disease, or side effects of the medications, including diabetes and high blood pressure, can also affect men's sexual function. So there's a lot of other things going on. If you have myasthenia, it's not that you just have myasthenia. You have myasthenia plus all the other things that are contributed through either complications of the disease, having a chronic illness. And so what are these medicines? And I broke them down sort of for simplicity on men and women. And the interesting one, so prednisone, everybody knows prednisone, right? It's a tremendous and terrible drug all at the same time. Certainly life-saving and certainly life-altering, unfortunately. But there's the emotional lability associated with chronic use of steroids. There's depression for some people, hair loss, and for men, the low serum testosterone is exacerbated by prednisone. Decreased libido, both in men and women, weight gain, bone demineralization. So others that also have some effects that are less thought of is mycophenolate with emotional lability, just related to mycophenolate, erectile dysfunction in men on mycophenolate or Celsa. Azathioprine and hair loss, mestinon causes its own predominantly GI side effects, but if you look down the list and list of people, there's some emotional lability that's increased on mestinon. Rituximab, plasma change, and IVIG, less associated with sort of men's and women's issues. So what do you do for the women? We know have to do. For men, what do you need to do? Well, you need to check the testosterone levels in men if they have any of these sorts of complaints. You should look at the testosterone levels and treat low testosterone, because it can contribute to a feeling of weakness as well as the myasthenia. And it's fairly easy to treat. And you should look for the other things, both in men and women with depression or more weakness, thyroid, diabetes, high blood pressure. Treat the other things that can affect vascular changes in the man. And then other medicines that may be responsible. May need to alter the medicine regimen. Treat depression, if depression exists, or have somebody treat depression. And if not solving men's issues, then urology is a good partner to have.